snowy day here in Denver, Colorado area, so it should be a good evening for a webinar. It was kind of a disaster on the neighborhood roads getting back home, but I'm back here at home and looking forward to presenting a men's health webinar today. So without further ado, we'll get rolling here. Quick a little bit about myself. Born and raised here in South Denver, and went to medical school on the East Coast at Penn, and then back for urology surgical residency here at University of Colorado. And then I did a men's health and prosthetic urology fellowship at UCLA in Los Angeles. And now I'm back in practice at University of Colorado with locations both at the Anschutz campus and also South Denver Highlands Ranch. I specialize in treating really everything men's health, but erectile dysfunction, Peyronie's disease, testosterone replacement, and male fertility. And I do some general urology, kidney stones, and prostate issues as well. So we'll go ahead and jump into it. The focus of the topic tonight is erectile dysfunction, or ED. So what is it? I always tell guys, you know it when you're experiencing it. It's essentially when a man's not pleased with the strength of his erection. But the technical definition would be the inability to achieve or maintain an erection firm enough for sexual intercourse. And the reality is this is a very common diagnosis. Over half of men over 40 years old have some degree of erectile dysfunction, or ED. And there's an age-related component to this. So the older we get, the more likely men are to suffer from ED. About 60% of men in their 60s, 70% of men in their 70s, so on and so forth. So, it goes to show very common disease and affecting almost 40 million American men. You can imagine, doesn't always dominate the golf course talk, but statistics would say that depending on your age, often more than half of your friends are suffering from the same issue with ED. So we'll delve in a little deeper to erectile dysfunction. So first we'll review the normal anatomy and physiology. For a normal erection, starts with sexual arousal, and the nerves that go around the prostate into the penis activate and cause the smooth muscle of the penis, which is, fills these two bodies of the penis called the corpora cavernosa, causes relaxation of the smooth muscle and causes blood to be drawn into the penis. And it's actually a fairly elegant mechanism. When that blood draws in and swells the inside of the penis, it compresses the veins on the outside here, which is the way blood leaves. So with the swelling, the exit veins are closed, and that allows a man to maintain a firm erection. And that would be normal physiology. So a little bit more about some of the causes and comorbidities associated with ED. The top three physical causes are vascular, otherwise known as vasculogenic erectile dysfunction, diabetes, and then medication side effects. And additionally, we know that erectile dysfunction can be the result of prostate cancer treatment. And this is a huge one. Prostate cancer is unfortunately the number one most common solid organ cancer in men. And so, we see lots of ED related to treatment from prostate cancer. We'll focus on that a little bit later. And then conversely, we know that erectile dysfunction can be a precursor to other systemic issues or other health problems, such as diabetes, heart disease, or peripheral vascular disease. So it's really clear that ED can have a broad negative impact on the health-related quality of life of many American men. So first, we'll narrow down on the connection between ED and diabetes. So we all know diabetes is very common, with 15 million American men suffering from diabetes. And the first thing to note here is that there's been good studies to show that patients with diabetes and erectile dysfunction are unfortunately less responsive to the oral medications like Viagra or Cialis compared to their counterparts. And furthermore, men with diabetes, their ED tends to be more severe, and they tend to have even worse quality of life, or decreased quality of life compared to their peers. And again, conversely, we sometimes know that erectile dysfunction can be the presenting symptom of diabetes, essentially the canary in the coal mine. which is why we always want guys to, tell your doctor you're suffering from this. We'll tell you about the treatment options, and then we can do some blood tests and look for other health issues that may be even more dangerous than erectile dysfunction. So certainly can be the canary in the coal mine and kind of a harbinger of other medical issues. So why is it that diabetes can cause erectile dysfunction? Really, that comes down to damage to nerves and damage to small blood vessels. So with diabetes, our blood glucose or blood sugar levels are elevated, and our nerves really don't like that. That's not good for nerves and can cause nerve damage or neuropathy. And similarly, small blood vessels also have a detrimental effect from elevated sugar levels. And so for these reasons, some of the medications that we commonly use, which normally work very well to treat erectile dysfunction, but in the setting of diabetes, unfortunately, if the nerves, which carry the stimulation for erection, and the small blood vessels are damaged, we're not going to see the same response to these medications. So some other factors associated with diabetes and erectile dysfunction that may portend a more serious prognosis would be advanced age, diabetes duration, poor glycemic control or blood sugar control, vascular disease, diuretic treatment, which tends to be kind of blood pressure related medications or medications to help guys who have too much fluid, and even heart disease. So now we'll kind of shift focus here to erectile dysfunction and heart disease. So, heart disease is a huge issue in America, very common. And unfortunately, we know that the symptoms of heart disease may develop within only 2 or 3 years following a diagnosis of erectile dysfunction. There's a clear link there. Again, getting back to that canary in the coal mine analogy. So ED is certainly an independent risk factor for future health-related events, and the severity of erectile dysfunction is correlated with the extent of coronary artery disease, which is heart disease. So why is that? Why does erectile dysfunction tend to precede coronary disease? And that really comes down to the size of the arteries at play here. So we have a nice graphic here showing different size arteries. On the left, the penile artery, small but important, I always say, 1 to 2 millimeters in size, whereas the main artery supplying the heart, the coronary artery, is about twice that size. So you can imagine as we develop plaques or blockages in our blood vessels with aging or, poor diet and exercise, that the smaller arteries will be affected first. And with just 50% obstruction of the flow, then the artery can be compromised and cause symptoms of erectile dysfunction. So, doc, I hear you. What can I do to reduce my risk? I've got erectile dysfunction. I'm worried about my future heart risk, or what can I do to improve my heart health? First line options is trying to optimize your lifestyle, and these really do make a big difference. So working on our diet, reducing the number of calories we take in, and reducing saturated fats and more fruits and vegetables. Exercise, physical activity, try to shoot for at least 30 minutes of vigorous activity 4 times per week. Weight loss, cutting 10% of total body mass can really help cardiovascular health. Quitting smoking, certainly, and then reducing stress as we're able. What about erectile dysfunction in low testosterone? So what exactly is low testosterone? First, we'll talk about testosterone itself. And I explain this to my patients that testosterone is the quintessential male hormone. It's produced by our testicles and really has 2 main functions. First is it drives and modulates our sex drive and libido. And then second, it gives us energy to get through the day, to want to get through the workout and excel at the workout, and then let our bodies recover. So kind of an androgenic effect, an energy effect as well. We know that low testosterone is more common in men with obesity, diabetes, high blood pressure, high cholesterol, prostate disease, and even asthma and COPD, which is especially common here in Colorado. So, what else about low testosterone? How many men are estimated to have testosterone deficiency? And it's also fairly prevalent. About 4 in 10 men over the age of 45 may have low testosterone. And in fact, once we get above the age of 30, men lose about 2% of their total testosterone per year. So I always encourage my patients, if you have any, concern you may have any of these symptoms, fatigue, low libido, erectile dysfunction, go see your doctor. We'll get some blood tests and we'll see where you're at. And uh, testosterone replacement therapy really can be a game changer for many men, especially when it's done safely by a urologist or men's health specialist. And the mainstay of treatment would be testosterone replacement therapy via gels, injections, or testosterone pellets. What about ED and prostate cancer treatment to be specific? So this is a nice graphic here kind of showing the relevant anatomy. You can see that the prostate sits under the bladder, and those nerves that control erectile function pass right outside of the prostate. And anytime that the prostate needs to be surgically removed due to prostate cancer or treated with radiation, the nerves that are so intimately associated with the prostate will be affected. One great treatment option is the new nerve-sparing approach for a robotic radical prostatectomy. But even with the nerve-sparing approach, some of the nerves will be injured, and generally men will have not quite as strong of erections after prostatectomy as before. And sometimes it can be quite a significant drop-off. Some men will see a rebound, and some men not so much. But unfortunately, this is the truth of it, and it's important to know on the front end. So what do the data show? This shows that how many men after prostate cancer treatment suffer from sexual dysfunction, and these studies have quite a wide range, 25% to 75%. Why such a big range? Well, I'll tell you, my thought is that, in my experience, oftentimes a man diagnosed with prostate cancer, there's a rush for treatment. He's treated, following tests with his prostate cancer doctor or oncologist. Everything's looking good. Hey, you're cured, great news. And sometimes the conversation stops there. But the more you speak with these patients, the more you can tell, hey, doc, cancer is gone, but I'm still dealing with some other issues that are important to my quality of life, erectile dysfunction, sometimes some other urinary issues. And this is really the heart of my practice, is helping men regain intimacy and improve their quality of life after prostate cancer treatment, kind of a survivorship model. So I should say it's not just surgery that has these effects. Also with radiation, about half of men will experience some type of sexual dysfunction after radiation therapy for prostate cancer. What about ED and Peyronie's disease? So what exactly is Peyronie's disease? This is the bent carrot disease, if you've seen the most recent marketing campaign. But this is essentially acquired penile curvature that develops later in life, and it's due to a scar tissue that forms on the top of the penis, as you can see here in this graphic. It happens because of a combination of bad luck and inappropriate wound healing from our body. And that plaque is made of scar tissue and is less stretchy, less elastic than the remainder of the sheath of the penis. So when the penis fills with blood for an erection, there's some puckering around that plaque causing curvature. And not only can it cause curvature, but also is associated with erectile dysfunction, penile shortening, and not to mention, certainly, as you can imagine, anxiety and stress about appearance, and even some issues with sexual intercourse. So, now more than ever, there's several different treatment options for Peyronie's disease. There's non-invasive injections, also called Xiaflex injections, course of 8 injections stretched out over several months to slowly degrade that plaque to help get reduce some of the penile curvature. There's surgical options, as mentioned here. And there's also penile implants, especially for men who are suffering from both ED and Peyronie's. A penile implant can really solve both those problems and be a game changer. What about the treatment options for erectile dysfunction? So, first we'd be remiss if I didn't mention some of these newer type of regenerative type treatments. And the issue here is that we don't have all the data yet. And so our national guidelines make clear that any of these treatments, which would be shockwave therapy, also known as low intensity shockwave therapy, stem cell therapy, or PRP therapy, also known as P-shots, all of these should still be considered investigational. We don't have data showing they're A, safe, or B, effective yet. I would say that for the shockwave therapy, the first one, low intensity shockwave, there are some more and more data coming to light now that these are safe, and they do seem to have some effect, but a pretty small effect, and much less of a marginal difference than even the medication. So hate to see it when a man has spent thousands of dollars on a hope and a prayer and hoping to solve his problems, and really we could have told him with moderate to severe ED might not have been the treatment for you. So again, in summary, these new treatments at this point should still be considered investigational. But let's now move to the mainstay treatment options that you may be familiar with, and we'll go through these one by one. So first, we have oral medications, and these work by increasing blood flow to the penis. They increase a molecule called nitric oxide in the penis, which drives blood to flow into the penis and facilitates erection. They don't give a man erection automatically, but they lower the threshold that it takes for a man to achieve an erection with arousal. They're generally pretty effective medications, and they work in most men, 60 to 80%. They can be affected by food, specifically sildenafil or Viagra. Cialis, less so. Most common side effects would be headache, facial flushing, upset stomach, and sometimes some muscle cramps with Cialis. Main contraindication or thing to have to take caution with would be if you take nitrate medications for chest pain, then unfortunately these medications aren't safe and not an option for you. So what about penile injections or intracavernosal injections? These are a nice option for many men, and they do work fairly reliably. It's a self-injection where a man takes a syringe and a very small needle to inject medication directly into the body of the penis, which then stimulates an erection in about 5 to 15, 20 minutes after the injection. And again, they do work in most men. The issue with these is that, as you might imagine, it's sticking a needle in your penis, not something that most guys ever thought they'd be doing. And so when we look at studies looking at men using this form of treatment, about half of men, 40–50%, will drop off within 6 months. Most common side effects would be some penile pain, a prolonged erection, some scar tissue don't see that too commonly, but there is a risk of that, or certainly blood collection or hematoma at the area of the injection site. So we'll move on here to the vacuum erection device, or VEDs. Another great option. This is a non-invasive option where a sheath is placed over the penis, and then a vacuum is used to draw blood into get a negative pressure environment in the sheath, which then draws blood into the penis, and then a constrictive band is slipped over to the base of the penis, as you can see in the graphic here. Fairly effective treatment, satisfaction rates ranging in the 60s to 80s. Most common side effects would be some pain or discomfort, issues with ejaculation, and penile numbness or coldness, since there's not new blood flowing into the penis once that band is applied. Most common reasons for discontinuation of the vacuum treatments would be inability to achieve or maintain a full erection. So now we'll move to urethral suppositories. So this is similar medication, the active ingredient, as the penile injections, but really for men who have a needle phobia, or just needles are going to be a non-starter. That's when we tend to turn to these, where essentially the medication is inserted down the urethra or down the P tube, and then the body absorbs it that way and brings blood to the penis. Success rates are a little lower, 40s to 60%. Some of the side effects, as you can imagine, might be some pain in the penis, some burning at the urethra, irritation with urination, sometimes low blood pressure or dizziness. And there's a variety of reasons why men choose to discontinue this treatment option, though it's certainly a good option for some men. Now, what about the penile implant? So this is the gold standard and the only permanent cure for erectile dysfunction. And there's a diagram of it here. How does it work? It works by a man squeezing the pump, which is located in the scrotum, which transfers fluid from the reservoir through the tubing and into the cylinders to generate a rigid erection. Very effective treatment. This option has the highest satisfaction rates from both the patient and his partner, in the high 90s, 98%, as you can see here. Most common side effects would be some pain or discomfort, especially initially when a man's recovering from surgery. And there's a low but non-zero risk of infection. And then finally, sometimes the devices can break down and require a revision. What are the different types of penile implants? Here are the three main types. There's the three-piece inflatable implant, which is the most common and the one I mentioned in the last slide. There's a two-piece inflatable implant that doesn't have the reservoir, and the fluid is just contained between the cylinders and the pump. And then there's a one-piece, if you will, called a malleable penile implant, where the implant is just bent up or down prior to sex, but a great option for men who have difficulty with their hands, maybe Parkinson's or a tremor, and have difficulty manipulating a pump in the scrotum. So a little bit more about the three-piece penile implant. This is the most implanted and the only implant with built-in antibiotic treatment. It's pretty impressive. There's actually 3 separate antibiotic medications that are impregnated into the device to help lower the infection rate. And that's been clinically proven to do just that, lower risk of infection. The nice thing about the three-piece inflatable implant is it's designed to most closely mimic a natural erection. It's strong and rigid when it's inflated and works as long as a man wants to enjoy the erection. And then afterwards, with a deflate button, it goes down to a natural flaccid appearance when deflated. And I'd like to highlight here that penile implants, they've really stood the test of time. They've been in clinical use for going on over 45 years now, and over 500,000 American men have received a penile implant. So again, it's often not something that guys are talking about on the golf course as much as they might talk about a knee replacement or a hip replacement, but these are really more common than I think most guys realize, and can certainly be a game changer for many patients. So I have a quick animation here to better explain how the three-piece penile implant works. Let's see here. So you can see on the outside, it's completely contained. Everything's under the skin. Looks normal from the outside when it's deflated. When a man's ready for erection, manipulates the pump to move fluid from the reservoir into the cylinders for a rigid erection. And then afterwards, hits the deflate valve and deflates back to a normal, flaccid, natural state. All right, so what to expect for the procedure? This is typically performed as an outpatient procedure under anesthesia. There's a small incision, either in the scrotum or above the pubic bone, and generally takes a few days to return to your regular routine of light activity, and then about 4 to 6 weeks before you're cleared to use the implant for sexual intercourse. I tell guys it's the rule of twos. 2 days you'll be, fairly sore, recovering from surgery. 2 weeks you're kind of getting through some of the swelling, and then about 2 months, 6 to 8 weeks until you're cleared and you get back to your baseline following surgery. What about the cost and insurance coverage? The good news is that most insurance plans will cover ED treatment, and I've had great success in my practice with both Medicare and Medicare Advantage. So what do men say about their experience here? We've got, we're lucky to have a patient advocate with us today, Cliff. So I'll let Cliff speak in just a second here, but I'll just review, John's story, who is a patient diagnosed with diabetes and high blood pressure and has had 14 years of a three-piece implant. It was the very first time I ever had surgery, and honestly, I was nervous, but recovery was pretty easy for me. Having the implant has been really great. I got my life back. So just a few more benefits here in summary before we hear from Cliff. 97% patient satisfaction, 98% partner satisfaction with the three-piece implant. It's been proven to reduce the risk of infection, affordable, typically covered by medical insurance. It's a long-lasting, permanent solution. 89% are still in use at 10 years, and it's a natural option. It's designed to mimic the natural appearance and function of the penis in the erect and flaccid state. I think one thing I'd like to highlight that the penile implant offers as compared to some of the other treatments is spontaneity. Guys with injections have difficulty when they're traveling, bringing syringes and needles on planes or road trips. Oh, I forgot the medication, or I had food, I can't take the medication. This is contained in your own body, and that spontaneity is crucial for many couples. So it is a surgery, and it's a low risk procedure, but not a zero risk procedure. So I make sure my patients are very well counseled as to the risks. Some of these risks would include, first, that should a man choose a penile implant, he can't then go backwards, can't use injections, can't use medications. Once you go down the penile implant, that would be the route you would take. There can be mechanical failure. It is a device, and that may require a revision surgery to replace the device. There can be pain, which is usually associated with the healing process and improves with time. And men with diabetes, spinal cord injuries, or open sores may have an increased risk of infections. But the infection risk is low, 1 to 2.5%. And we wish it were zero, but the reality is there's always a small risk. We do many things to keep this risk as low as we can with lots of antibiotics and other precautions, but that's important for men to know. So, in summary, ED is a common problem and may be associated with other conditions. I really like to think of it as the canary in a coal mine when it comes to men's health. And the good news is there are a variety of successful treatment options, and penile implants especially may offer a long-lasting and satisfactory solution. So with that, I'd like to turn it over to our patient advocate, Chip, who's, as I understand, braving a tornado, had a power outage in St. Louis. And so he's dealing with weather in St. Louis, just like we're dealing with weather here in Denver. But Chip, thanks so much for joining us tonight, and I'll turn it over to you. And then following that, we'll answer anonymous questions.
Fine. Good evening, everyone. First, I would like to say that ED, everybody thinks it's just a male issue. It's a partner's issue. It really concerns both people. And truthfully, the sooner you get your partner involved in the process of fixing and coming to a conclusion and ending the ED with the treatment option, the better off everybody is. I am 77 years old. When I was 58 years old, I had prostate cancer. It was only in one spot, but being the kind of person I was, I decided I did not want to keep it. I said, take it out. I don't want it to go anywhere, and I'll deal with the consequences later. Well, the consequences were ED. One of the consequences. I had the surgery, and after about 6 months, went back to the general doctor and told him, I said, I'm not getting any erections, and they gave me Viagra. Fortunately, I was one of those people that just could not take the pills. Viagra, the Cialis, and the Levitra gave me headaches that were just incredible. They were like migraines. I had to lay down. I couldn't take my head up off the pillow. So we did away with the pill therapy. The next therapy he gave me was this external vacuum pump. I will say it did work. I will also say it's very unspontaneous. And like the doctor said, your penis becomes cold. It kind of turns blue. It's not very satisfactorily looking to your partner. And the reality for me was taking the band off was painful. So after about 3 months of that, I gave it all up. And I went into a major state of depression because I had lost my manhood. I could not get an erection. I didn't know what was out there. Luckily, I got an invitation to a seminar just like this, and I found out about the implant. My wife and I talked about it, and we decided we would talk to the doctor. Spent 45 minutes with the doctor, and he explained everything to us. And the day after my 60th birthday, I did the second best thing I ever did in my whole life, and that was get the implant. First one was to marry my young lady, but the second one was to get the implant. Now I've had my implant, my first implant lasted 14 years. I came home from the hospital in about a week. The swelling started to go down. By 2 weeks, most of the black and blue left. By 3 weeks, I was back at the doctor's office and he was showing me how to use it. And then he said, when you get used to using it and you feel comfortable, you can go back to having relations. And my wife and I waited basically till the beginning of the 6th week, and we started to have relations. And I will tell you, it brought back an intimacy that we had lost and never even knew we lost it. But the intimacy was phenomenal. And I felt like an 18-year-old. And my wife looked at me and said, I don't want an 18-year-old anymore. So the issue was basically that it's there with you no matter where you are. You just reach down, you do pumps, and you get a solid, rigid erection that's good for any type of intercourse you want to have. People ask me questions about it, and what they ask mostly is, well, when you go through the airport, does it go off when you go through the metal detector? No, it doesn't. Or they say, okay, I have knees that have artificial knees, and it goes off the artificial knees, and then they take this wand and they wand your whole body, and they go on the inside of your thighs and over your crotch. Nothing happens. It's total nothing. It's not there as far as they're concerned. It doesn't stop anybody from having any type of MRIs, CT scans, PET scans. Some types of implants do not allow that. This one is not a problem. The other thing is it has nothing at all to do with your urinary system nor your bladder. So if you need to have a cystoscopy or something, not a problem at all. It's totally separate. After 2 weeks after the surgery, I went back to work. After 6 weeks, we started having relations. At the 6 week mark, I also went back to the gym with the guys I usually work out with, shower with them. They have absolutely no idea there's anything inside me. It's incredible. And all I can say is that it brought back to me the manhood that I had lost. And it made me a whole man again. I will say one thing about these erection devices, these external vacuum devices. If you want to get one, ask your urologist for a prescription from a medical supply company. Do not go to Adam and Eve or any of these sex places for $25 and buy one. Those are garbage. You really need a good one. And it might cost a couple $100, but let me tell you, it works. And that's the only thing I can say. Outside of that, all I can say is after 14 years, I had a revision done. My new one has been in for 3 years now and works like a champ. And if I have another 14 years worth out of it, I'll go in for another one. Simple as that. So I'll turn it back over to the doc for questions if you have any.
Cliff, hey, thank you so much. It's always powerful to hear your story and the way you phrase it, and thanks so much for sharing that. It's really valuable for the different men on the call. One thing that I want to highlight is you mentioned that part of the regaining some of the intimacy you didn't even realize that you lost, and I've had patients mention that to me too, especially when things start slowly. Doc, in retrospect, it was there. I didn't really even fully appreciate it, and I've discovered something new here. So I just wanted to mention that. And regarding the vacuum erection devices, you're absolutely right. You really get what you pay for with those, and there's just no sense in bothering going on Amazon and getting the low quality ones. They're not going to work. So your urologist would always be happy to give you the appropriate recommendations for medical grade devices.